I'm Nazi, that's me.
You're recording.
Okay, so what I did while we were having all of our talks this morning is I went on Facebook and I just asked if anybody had questions they wanted to ask. So some of the questions in my hand are ones that you've given me, and some of them are ones that I've gotten off of Facebook. And hopefully all of you have learned so much today that you can answer some of these questions and recognize that some of these people could benefit from being here. So some of these questions might sound, wow. It's fine, all right? Some of these questions may sound to you as though they already addressed this, but I wanted to actually ask them again just for the purpose of those who don't have the answers, and perhaps it's good review for all of us anyways. So the first question I have is more of a genetics line, but anybody can answer it who would like. Can you have NPS with no outward signs in the family with people who have obvious symptoms?
The short answer would be no. As I said, the most commonly seen feature of nail patella syndrome is some sort of nail dysplasia, and so everybody essentially with nail patella syndrome has some nail dysplasia, and they may have no obvious problem with their knees, their kidneys and eyes may be fine, but if they have the same mutation in LMX1B as their more seriously affected family members, then they will have some nail signs. So it's looking for just a bit of the thumbnail missing, the lack of creases over the top joint, triangular lunuli, things like that. If those are completely normal, then it's highly unlikely that they have nail patella syndrome.
Okay, thank you very much. I'm going to just carry on with my questions. If any of you would like to make a comment or need some clarification, just go ahead and raise your hand and we'll address it that way. But I do have 21 questions, so I want to make sure we are able to address them all. Next question, does NPS include polycystic ovary syndrome? Is that a quick answer?
No.
Okay.
No, it doesn't. No, it's not got cancer.
Okay. Is lots of dry, peeling skin common in NPS patients?
Not to my knowledge. What does everybody else think?
I know a lot of people complain about lots of extra skin on their hands. Does anybody?
Yes.
But it's loose skin. I wouldn't say it's dry. Yeah.
Some people complain about dry skin. I mean, it depends on, in general, but I think it might be less coincident.
Environmental more than.
I have it only on my right hand, though.
That's the one that counts the money, doesn't it?
I have left-handed, though. That rules that out.
In Ehlers-Danlos, that has, because one of the things that's affected in NPS is collagen. In Ehlers-Danlos, you can get dry skin, I believe. You can also like soft, downy skin, as well as some people have the skin will be more lax. They call it, you can pull on it more and release. Not a bit, depends on which type you have.
Okay. Any way to avoid my sorry.
I was going to say, I'm sorry, can I go on that question now? Can hair and nails be affected by nail patella as far as like being dry or brittle?
Can hair or nails be affected? Hair, no, not to my knowledge. Nails, they can be brittle and more prone to break, but again, it's because they've not developed properly rather than anything else.
I think there's also a higher incidence of like receding hairline and things like that in nail patella.
Again, that's more of a formation pattern issue rather than anything to actually, do with the hair itself, the structure of it.
And I have different toenails than all of you.
Everybody, I think, has different nails than everybody else.
Toenail then
Yeah.
mine are teeny.
All right, next question. Any way to avoid my children getting NPS? How can I know if my child has NPS or not?
Still for me. As I said in the talk, you can, if you or your partner have nail patella syndrome, then genetic testing in utero would be possible, and then what you do with that information would be up to you. You can also avoid having kids with NPS by doing sperm or egg donation, depending on which one of the two has nail patella syndrome. So then the child would then still be half yours. And once a child is born, then it's the clinical diagnosis, as we discussed before. And as Susan was just saying, you can see straight away at birth, once you know what to look for on the fingers, whether the kid has inherited the mutation or not.
Related to that, is anyone doing free DNA testing? Sorry, I just have a follow-up question to that one.
That was gonna be basically the same. I was just, last I had done some research that I could tell in utero, I think at the beginning of the second trimester, but I was wondering, is this something that is ever going to be possible to tell in an unfertilized egg or in a fertilized egg before implantation into the body?
Current testing would be towards the end of the first trimester, so around 11 or 12 weeks. Pre-implantation genetic diagnosis, as I said this morning, is theoretically possible. I'm aware of one person with Patella syndrome having had it done in Australia, but it's technically very difficult, and as technology improves, it theoretically could become possible. But it's IVF is not straightforward and doesn't always work. So you could get a perfectly, you could have the diagnosis spot on, but if the IVF doesn't take, then it's not going to work out. And there are we're now becoming aware of more risks with IVF than were previously thought.
Can you tell what IVF stands for?
Oh, in vitro fertilization, sorry. Test tube baby.
Related to that, is anyone doing free DNA testing? I'm wondering if my daughter has NPS since I do.
No, but it can be ordered by, I'm not aware of anyone doing it for free. It can be ordered as a straightforward test by a medical professional, and I can give you the website that lists the labs that do it.
There's a couple of centers in the United States that do the testing, correct?
Right, there's at least 3 in the United States off the top of my head I can think of. Baylor, GeneDx in Gaithersburg, and the lab in Allentown, Pennsylvania.
And Gene Tests has, for any given disease,
Right.
will have all of the labs in the world that do testing.
So that's genetest.org, has a listing of all the testing labs for any particular disease. Usually, yes, can be done that way.
Okay, I have a question for the audience because I think Ian went through this so often, you should all know the answer. We'll test them. We didn't tell them there was food.
Yeah.
Can my daughter pass on NPS to her children even though she doesn't have it, but I do?
No.
No. Correct.
Yes. Listen.
You did it.
Sorry?
I said unless she actually has it and just doesn't have any symptoms.
Correct, but if somehow
But she's had a DNA test.
right. So she's confident somehow she doesn't, so her child cannot. All right. Is chronic fatigue syndrome associated with NPS?
I actually don't know because I haven't asked that question before. I can conceptualize that it would be. But so if you could share with me, how many people feel like they might have chronic, or maybe you don't want to say chronic fatigue or fibromyalgia? Yeah, it makes sense. I mean, Ehlers-Danlos, it's a real problem. And even if it's not kind of quote, yeah. Oh, thank you. Yeah, okay, thank you. So yes, it's the way doctors, you sit around a table and say, we're going to call this chronic fatigue, and we're going to call this fibromyalgia. One day we'll understand these, and it's not going to be kind of just diagnoses that we've made up. Definitely, like in Ehlers-Danlos syndrome, there's a lot of chronic fatigue, and the things that we try to do for that in general in chronic pain and fibromyalgia is do exercise daily. Of course, you'd be choosing exercises that you're able to do without pain and low impact. Really essential. With chronic fatigue, there's a component, and I think, Ian, I don't know I think you were kind of indicating probably not. We were talking about Ehlers-Danlos and NPS, but where the blood pressure can be lower, and that can be part of a part of the problem, that kind of the autonomic system, the nerves that control the amount of blood that's kind of pumped through the body, the rate and the tone. They'll talk about tone of the blood vessels. You actually want to do exercise daily to kind of keep that intact and working properly. The exercise tends to help chronic pain anyway, and it will help sleep. Often, though, you have to do exercise routine for about 2 months before it starts to regulate sleep. Although some people find exercise kind of calming and soothing and meditative.
Thank you. Next question. Are inguinal hernias associated with NPS as a result of bearing more weight on the lower part of the body due to limited arm extension? Does that make sense? I think the question is can you get inguinal hernias due to the gait you have from the various...
I would think not. I would say it's an incidental finding. It's not part of the syndrome.
Usually inguinal hernias are involved with increased intra-abdominal pressure. So we see in peritoneal dialysis quite commonly, because if you're walking around, if you're an adult, there's this pressure all the time, and there's virtual spaces that open up. So it's, in my experience, it's associated with increased intra-abdominal pressure.
So when an inguinal hernia is down in the region kind of where the thighs meet the abdomen, some of the gutter tissue will pop out a little bit, and people often do surgery for that. And he's also mentioning that you can have that kind of pressing through the tissues up near where the navel is.
The next question, I'm not 100% sure I have it correct, and it might be for Steve or somebody else. It was thoughts on insole realignment on a teenager. So INSALL. Now, I don't know if that's autocorrect on the computer. It's supposed to be something else, or if that's truly a procedure.
Well, that's a soft tissue procedure that we talked about before,
Okay.
and that's okay. You don't want to do any bony procedures on children, especially if they still have growth remaining, because if you damage the growth plate, you can have that area of damage will stop growing, and you can have angular deformities and issues like that. So any soft tissue procedure in kids who aren't growing is fine, and they work very well.
Moving on to a very different topic, is constant gas and bowel problems associated with NPS?
Why do you keep pointing at me? You thinking I'm full of it or something? Irritable bowel syndrome, chronic constipation, the variants in that spectrum may seem to be a bit more common in nail patella syndrome than one might generally expect, and would fit within the spectrum of chronic fatigue syndrome and fibromyalgia and so forth, and possibly be the result of low levels of serotonin. Or it could just reflect what you eat.
And also, since you're mentioning GI, a lot of people are complaining about nausea, and often when we think of nausea, we think of something happening in the gut, but there's also, nausea is actually, the sensation is in the brain, so it could be kind of a central nausea, and that might be related to the serotonin actually in the brain, although 90% of your serotonin in the body is made somewhere in the gut, but so it may be actually more of a central nausea. Yes? You mentioned, I'm not sure if it's related to IBS, but your lower abdomen, it makes you feel nauseated? Yeah, very. Okay. Yeah, the gut has various transmitters that send messages from the gut to the brain. And it makes, and people, I don't know that much about IBS. I have a CD to listen to. I haven't done that yet, but I imagine nausea can be a part of that. I'm not sure. You can be, yeah.
Okay, this is back to
I would sorry, just to finish off on that point, just based on where we see the gene being expressed, and knowing that LMX1B is so involved in the development of the nervous system, it's going to, I would say, it's more likely to be anything that's in your perception of what your gut is doing It's not necessarily what your gut's doing, it's how you're perceiving it.
But
It's
if
not
you're
your fault.
getting input from the gut because of IBS, it
Right.
could work
It
differently
could work up
through
there.
the central mechanism.
Or it could be the other way because of a lack of serotonin in the brain affecting other things.
Is there a way for somebody to test their serotonin levels to see if it's in the normal range and see if it might be affected?
Brain biopsy, I guess.
Serum levels.
Not usually. You'd have to actually get the fluid that goes in the spinal canal to actually measure what's in the brain. You can get blood levels and, draw it from your arm, but even that, nobody really knows what it means anyway.
It's just
So
an awful
it's
high percentage of NPS sufferers that have IBS.
Yeah, I mean, there's definitely something. I mean, that'd be helpful if.
There's some connections somewhere.
Yeah, that's where we need more information. Maybe we can do, if anyone's willing to help out in this, to contact Ian, and we can kind of get a list. We can create a study where we can measure this and try to figure out if it's one certain mutation, and find out what have people used that's been helpful and what hasn't been helpful, and then to be able to share that information. Yes. Go ahead. No? Oh, okay.
In relation to what we're talking about now, the patients who have been on the serotonin reuptake antidepressants, if this was the case with the serotonin being deficient causing nausea and IBS, wouldn't you expect to see some improvement with those symptoms?
So people on serotonin, you think would have an improvement in the nausea and the IBS and those things? That's what you're asking?
Yes.
However, hypothetically, if you had very low serotonin production, you might think that a serotonin reuptake inhibitor, which is what the SSRIs are, might have an attenuated effect because you're basically having your serotonin do more, but if you made
So
a
little in the first
low
place.
enough amount, it may not have the same type of effect as it would as someone
Right.
that had a more minor
They
thought.
put me on Prestige, which is an SSRI, and its effect on me was pretty much, I was catatonic and my ears didn't stop ringing after I took only 3 days of it.
I would stop that.
3 days, they kept telling me to hang in there, that the effects would go down after 2 weeks, and I said, I can't stand the ringing anymore.
Yeah, unfortunately, the side effects can be fairly widespread and unpleasant.
It was really bad. Very bad.
All right, and moving in a slightly different direction again. Do older parents have less of a chance of passing on NPS?
No.
Unless you mean in the sense
And,
that
other than less chance of having children anyway. But no. If you're still young enough to have kids, then it doesn't change and you have NPS, then it doesn't change the chance of passing it on.
Okay. Now I have a number of eye questions for Sam, so if you want to pass him the doodad. Several questions here and a couple follow-ups, so be patient. Are high pressures associated with pain and twitching?
Yes. No, they are, but it also depends on the rate of rise of the pressure. You can have a patient who walks into the clinic with a pressure of 60. Remember what normal pressure was? Between 10 and 22. But and he took, or she took, a month to get to that pressure. They have no pain. You can have a same patient who has a pressure of 40 that's developed within 24 hours come in crying like a little girl because it's excruciating pain.
it's gender discriminatory.
Well, no, because that means they're tougher. Because if they have to cry, the boys will cry anyways. So,
Okay.
yeah,
next
it
question.
depends on how fast that pressure rose.
I
So
see.
don't depend on pain. Twitching, no, that's not usually a feature. If you look at raising an elevated intraocular pressure, either gradually or rapidly, twitching is not. Usually, it's pain.
Twitching in the eye.
Yeah, twitching the eye would not be on that list. It would be tearing and sensitivity to bright light. Those would be the big symptoms first. Yeah.
I see floaters and colors at times. Is this associated
Welcome to
with
the club.
glaucoma?
No.
Old age.
Well, it's welcome to the club. I've got floaters. And does anybody not have floaters on the panel? I think there we are. It's very common, and you remember that gel matrix, the big ball of gel? It'll happen to all of us. Some people say, well, I don't have floaters. The question is they're probably very peripheral, that they haven't noticed them, but it's a matter of time that we will notice. Yes. But if you see a sudden increase in floaters, that's a telltale sign that you need to see an ophthalmologist, because it may be that it's pulling hard enough on the retina that it could cause a small little tear. So
That's a retina issue, not a glaucoma issue.
Immediately.
Yes,
Yeah.
thank you.
Eye emergency room.
Yeah, and it's not related to NPS, at least we know of.
All right, does the stigmatism affect the type of glaucoma you can get?
No, but what is astigmatism? Does everybody know what astigmatism is in principle? A simple analogy is, if I take a camera lens and it's perfectly round and it's nicely dome-shaped, say it's made out of plastic or rubber, and I squeeze it in a vise so it's no longer round but it's egg-shaped, that's basically what astigmatism induces. So when you look at an image, if I take a spot of light from a candle or a flashlight and I shine it through a perfectly round lens, it comes to a point focus. If you do the same thing with an astigmatic lens system or optical system, it comes as a streak. It's not nicely focused. So how you counteract it, you actually put a cylinder, a type of lens that is more cylindrical in front. So they usually grind that in either the glasses or rarely contact lenses. But that in and of itself is not, as we know of, elevated in NPS. But the rest of the question was, does
Affect the type of glaucoma you have?
No, it does not. But if in extreme cases, it can influence the measurement of the pressure. So there's ways to correct for that. In other words, if you have a very curved cornea in one dimension or one axis, which gives you the astigmatism, there's ways of measuring it that you have to factor in, otherwise your readings can be off.
All right, any concerns with doing near work or distance work with your eyes if you have glaucoma? Does it matter if you're always focusing on near or far?
That's a good question. Some of the drops, actually a lot of the drops, have an effect on the ability of the ciliary muscle. Remember the muscle that does two things: the ciliary body makes water, but also zooms in and out. It can slow those things down. Actually, some of the medications, a lot of the antihistamines, the things you take for allergies and so forth, can affect. Now, if you're in the youngish range, which we're not, that ability can be overridden by the fact that they have such a dynamic range of focusing. But if you're in what we call presbyopic, which is another nice Greek word for vision of old age, so that it can often tip it, so that you're finding that with your current spectacles or contact lens, it's not quite doing it, so it does blur.
This next one is a pretty general question, probably for Steve. What can be done about shoulder pain, muscle tightness, foot pain? I mean, what is your general recommendation for the general aches and pains of NPS? I guess that would be a good way to rephrase that question.
Well, there's really no good answer for a question like that, because the spectrum of disease and pain and quality of pain varies from person to person, and the way it affects you is very variable. But I can say that one of the things you could do, we talked about before, is having a well established program of physical activity, which uses your entire body, all of your joints, your shoulder, your neck, your back, your shoulders, and everything, and just also aerobic conditioning, if you're able to do so, and low impact type of exercises to help get your feeling of well-being established. And we talked about that before, and I think that's really important. But to talk about your whole specific joint, we'd have to talk to you personally and evaluate you and give you more advice in that way.
Right, a kind of follow-up question to that. If you were to take inflammatories, are there any available now that are safe for our kidneys, something like Vioxx that used to be available? Is there anything like that that's available now?
Well, Vioxx is good for your stomach, not your kidneys, and of course raised your risk of heart attack. So there's a little drawback to any of these things. The people who get what's called analgesic abuse nephropathy, which you can get from Tylenol as well, generally speaking, it is daily use of maximal or supramaximal doses for years.
And nephropathy is abnormality of kidney.
Yes.
Right, one of those. So the thing is, if you're using it I must say, using it in a reasonable amount. Daily, daily means probably you need somebody else to work on another way of dealing with it. The anti-inflammatory for osteoarthritis, so Steve is saying, that's kind of hard because anti-inflammatory type of stuff, that's us for NSAIDs, that's what they're made for. But anytime you do it, again, you may be immobile and think, I'm going to go from a given 2% chance of a heart attack in the next 5 years to a 4% chance, and I'm willing to do that because I'm going to be able to walk. And so anytime you use any drug or have any surgery, ask yourself, what am I getting? What risk am I taking? And so just remember that long-term sustained use, even of Tylenol, can cause damage to the kidneys, and in the case of even just Tylenol, it's 4 or 5 times background risk. The background risk for most people is very low, but it's a pretty substantial risk. So there's no drug that only has the good effects because it's the same hormone system, the inflammatory system, the so-called prostaglandins that are being affected for its effect everywhere.
Follow-up to that one, is gabapentin or Flexeril okay for our kidneys?
Gabapentin is okay. Flexeril is a muscle relaxant, right? So it shouldn't have any effect on the kidneys either. But always, again, specifically if you have decreased kidney function, first thing is your kidney is responsible for the excretion of both native drug and metabolites in an awful lot of drugs. So if your kidney function is substantially decreased, so under 50% of normal, your dose of any drug may need to be changed, and you should harass or ask firmly your practitioner if there is a change needed because of your kidney function. And then what I would recommend, because a lot of practitioners don't know it, is double check with the pharmacist before you even do it, because a lot of things have to be done differently. A lot of things, your risk of a side effect will increase if you have decreased kidney function. So that is for any drug, basically.
Tens.
Yeah.
Yes, Nancy.
I have a question about your saying Tylenol. For many years before I knew that NPS should stay away from NSAID for aspirin because of the kidney problems. Right away, my doctor, I was on aspirin for a long time, taking it on a daily basis for many, many days and weeks for chronic pain. I'm getting embarrassed asking about this. Anyway, then they took me over, they told me to take Tylenol. And I'm still taking Tylenol. Now I hear you say this, and I take it on a regular basis every day.
A large dose?
What would you recommend if you can't take aspirin or Tylenol?
Well, again, the thing is, to what degree would you be disabled without it, and are you willing to take somewhat of a risk? The worst results are for the NSAIDs and something that probably isn't even available in the U.S. anymore that used to be called APC, which was Tylenol, phenacetin, and caffeine, of all things. You know, a lot of people that, find that their headaches are helped by a cup of coffee. And those three together literally were able to induce kidney failure. In Australia, basically, analgesic abuse nephropathy was 15% of all kidney failure at one point. Well, it helps with the pain. It helps because it causes vasoconstriction in the vessels of the brain. Unfortunately, it works synergistically with the other things. So a lot of it has been shown in combination. But Tylenol itself is very, and everybody knows in terms of an overdose and causing liver failure. So that it's a big, I see it in pediatrics, it's a big suicide modality for girls mostly. And it's a very unpleasant way to go, to have your liver toasted. And here's this thing that's ought to be safe, and it's like, but enough of it is not good for you. And it is actually in high doses toxic to the kidney, not just the liver. So any of these things, again, just think in terms of the trade-off, watch the dose you're getting, and if you're needing a drug that has significant side effects constantly, I would say going to a pain doctor and saying, if I got another modality that may not be drug-based or may allow me to be synergistic. I put kids, so I'm a hypertension expert. That's who takes care of hypertension is the kidney doctors in pediatrics. And we have a little patch we call Catapress, which is a clonidine patch. And clonidine works on the brain. That's how it does it's blood pressure things. It actually also happens to be really good, and our pain doctors use it for pain all the time.